Hi, good morning. Do you have the mic on already, or may I just use this? I know people will keep trickling in, but I just wanted to introduce you to our speaker today, who traveled late last night to arrive from Augusta. I'm sure is a Georgia fan, and maybe got your heart broken a little bit. I don't know. But anyway, Dr. Johnson we've kind of gotten connected through collaborations with patients who are some of our patients who have gone to participate on a clinical trial that he's running in Augusta, which is a really interesting and unique immunotherapy trial in combination with traditional radiation and chemotherapy as well. And so I'm really excited to have him come and talk to us about that trial. And also we're developing some collaborations, and we'll be opening a portion of his trial here very soon to participate as well. So he was just sharing with me that he grew up in the Tampa and Space Coast area because his father was in the military, but went to undergrad at Georgia Tech and got a degree in chemistry, and then went on to the Medical College of Georgia, which is where we both went to medical school, so we have that in common, although I'm a little bit older. And then went on to get his MD PhD there in the medical college program. And then actually worked in the lab that discovered this IDO pathway that he's going to talk about today. Then went on to residency there at MCG, to Hematology Oncology Fellowship at Cincinnati Children's. And then came back to Augusta, and I'm not sure exactly which year.
2010.
In 2010. So wow, you've been now there seven years. So yeah. That's wonderful. So welcome, and we're very thankful to have you.
Thank you, Amy, very much. Thank you for the invitation. Always excited to talk to groups around, but especially Amy, who's been so helpful in taking care of the patients that we have from your program. So just before I get started, I want to highlight one of the things that's different about this immunotherapy treatment that we've developed in Augusta for kids who have relapsed brain cancer is that we actually layer the immunotherapy on top of what would be a conventional salvage therapy regimen. So that's pretty unusual in immunotherapy circles. Drug companies are really trying to replace chemotherapy and radiation with immunotherapy, and it's incredibly expensive. The drugs that have gotten approval mainly for adult indications, but the PD-1 blocking drugs and CTLA-4 blocking drugs are antibodies that cost about $100,000 to $150,000 a course, and the new CAR T-cell technology that's just navigating its approval process and the first drugs in that class have been approved. It's not clear at all where the insurance coverage is coming from for those $600,000, $700,000, and $800,000 treatments. So our thought was, and then another very important point is that there's not a lot of immunotherapy that is compared to the adult space. Immunotherapy in kids is really lagging behind, probably 5 to 7 years, maybe even longer, partly because of economics and partly because we don't have nearly as many patients, and that drives the drug companies to focus on the adults. Kids tend to be more responsive, though, to standard therapies. We have higher cure rates across the board, and that's really illustrative of the fact that kids have better responses to chemotherapy and radiation and even surgical control, and that's true also in relapse. It's harder to get control reestablished in relapse, but there's still often the case that kids retain some responsiveness to those modalities, at least initially. So our thought was that when we designed this trial, rather than replace what would be a perfectly good salvage regimen that has a published response rate associated with it, rather than try to replace that with experimental therapy that's untested and nobody knows if it'll work, rather than do that, we decided to layer the immunotherapy on top of conventional treatments. And I think that was, in hindsight, a really good decision. Adults have mixed experience with this type of strategy, but in large part it's failing in adult therapies the antibody-based therapies. And there are probably good reasons for that. The approach that we've used is a little different. So these are my disclosures. I really don't receive any direct compensation, and I'm not a paid consultant, but the drug company that's developing indoximod does provide financial support for the clinical trial. And objectives and something of an outline after this presentation. I guess there are some CME questions that I think if you focus on the design of the trial and think about what constitutes different types of clinical trials, what would define a phase 1, phase 2, phase 3, that sort of thing. But about this trial, I want you to understand a little bit about the design, how many kids we've enrolled, a little bit about preliminary outcome data, which is it's premature at this point, but it's beginning to show some trends that I'll show you, and the safety profile of this treatment in kids. So I'm going to start with what is the relationship between a growing tumor and the immune system. By the time a tumor comes to becomes clinically evident, it's already defeated the immune system. It's already figured out a way to hide itself from the immune system. The immune system you're born with is very powerful. It can reject whole organs that are mismatched. If they're mismatched kidney can be rejected with hyperacute rejection on the operating room table. It can turn black. Acute rejection is no picnic, and chronic rejection may take months to years, but eventually destroys the organ. So the power of the immune system to specifically reject a whole organ, which is essentially what a tumor is, it's just a foreign organ that shouldn't be growing in your body, and the specificity of the immune system to do that is very well established. The question becomes why it doesn't happen, and that's by and large because of immune regulatory pathways that we've spent the last 20 to 30 years discovering. IDO is one of those, and I'll talk about that as the focus of this talk. But the suppression that gets established, the immune system is essentially recruited by the tumor in order to protect it in very specific ways. And so not only is the immune system not attacking the tumor, but in some ways it's actively helping the tumor grow. Every time you give chemotherapy and radiation, the immune system, parts of the immune system are very well established components of the wound healing process. And so if your immune system is actually helping your tumor heal after each cycle of chemotherapy or each fraction of radiation, that's a really bad situation. But that's probably what happens every time we give chemotherapy and radiation therapy. So what is the pathway that we're targeting with this new experimental treatment? It's called indolamine 2,3 dioxygenase, which is why we shorten that to IDO. It's one of a class of drugs called immune checkpoint blockers, and along with T-cell checkpoints, which include CTLA-4 and PD-1, it is a regulatory mechanism by which the immune system can be suppressed specifically in order to guard against autoimmune or hyperimmune activity. It's expressed in a lot of different tumor types. It's been associated with increased tumor growth or metastatic potential in a lot of different tumor settings. It's a natural endogenous mechanism of immune suppression, and it's inherently counter-regulatory. So as soon as there's inflammatory signals in the tumor microenvironment after, say, chemotherapy or radiation, the cytokines that are secreted as a result of those treatments induce IDO immediately. And so that induction of IDO immediately begins to tamp down any immune response that may be trying to get established. And then IDO is known to regulate both adaptive and innate immunity in various ways, and the overall pathway is shown there just for information purposes. So what's the benefit in combining a strategy like IDO blockade, immunotherapy with radiation and chemotherapy? Can we lower can we get better efficacy than the backbone therapies without increasing toxicity? Overall, pediatric brain tumors are highly curable, about 70% or higher cure rates, but that's because the epidemiology is dominated by low-grade gliomas, which can often be resected and as a curative modality. In the relapse setting, or if you have a tumor type that's more likely to relapse, those cure rates are not nearly as good. And the salvage therapies, the conventional salvage therapies for relapsed brain cancer often don't bring much to the table. There are some cases where they do, but there are a lot of cases where they don't. In the case of relapsed glioblastoma, radiation and chemotherapy really don't work very well. You can sometimes temporize, but not really change the outcome. Relapsed medulloblastoma, a lot of these patients in the complicated cases have already had autologous transplants and even sometimes multiple autologous transplants. So they're very weak when they get to the relapse stage, and their tolerance for additional therapy is very low. And then relapse ependymoma, there's certain cases where you can do re-irradiation at a second full lifetime dose with reasonable outcomes. But there are a lot of patients who can't get that treatment. Either they have a pattern of metastatic disease that with active tumors that overlap into previous radiation fields that would be too dangerous to give additional radiation, or if you can't hit all sites of disease with your new radiation plan, or if you're not in full relapse, first relapse. These are all cases where kids are often not offered radiation. Some centers will and some centers won't. But you get the idea that the standard therapies have a limited effectiveness in the relapse setting. So what does immunotherapy bring to the relapse setting? So once you've run through your conventional options, you really are left with two possibilities that you can use to care for the patient. One is sending them to hospice care. And in the case of brain cancer, the functional decline is fairly visible. It's very tangible. These are patients who have major, nerve deficits that play out over time and worsen, very distressing to the patient and the family, but ultimately universally lead to death in hospice because you're not treating in any way. How does the phase 1 drug development space change that? Well, not a whole lot, actually. The phase 1 drugs even sometimes will add additional toxicity to what would otherwise be a relentlessly declining hospice course, plus you add the toxicity of the phase 1 agents. And so sometimes you actually complicate end-of-life issues by using phase 1 agents in this patient population. So our hope was that immunotherapy would allow us to change that paradigm, at least partly. So we started with some hypotheses that immunotherapy, one, could be combined effectively with conventional therapies such as radiation and chemotherapy, and that it would allow us potentially, if the immunotherapy is effective and you're getting more efficacy with the standard therapy backbone, can you dial down the dose of the chemotherapy? Can you dial back the intensity of the radiation? So the idea there is, can you begin to control some of this late phase toxicity that complicates end-of-life care? If you can, there may be quality of life reasons to embark on a therapy, a combined immunoradiochemotherapy treatment in late stages of cancer progression, just on the basis that you can provide better quality of life and maybe even extend life in a situation where people can still use the functionality that they have. So the bottom line is, will adding immunotherapy to the standard treatments allow us to reintroduce aggressive multimodal therapy in a setting where the practitioners have, in some cases, succumbed to a learned helplessness, a sort of treatment paradigm. There's nothing that works, there's nothing that we can do, and we just have to be finished. And that's right when all you have to offer is toxicity and debilitation. But if you can offer more than that, then maybe we can re-engage surgical modalities. Maybe we can re-engage radiation. Maybe we can re-engage chemotherapy options. And that's what I think immunotherapy brings to the table in kids who have late-stage cancer if you can successfully combine it with standard therapies. So this is an old list of drugs that block IDO that are in development. The components of the list haven't really changed that much. There might be a couple more that could be added, but they're a little further into development than they were 3 years ago when this was published. Epacadostat is made by Incyte. It's in phase 3 trials now for a variety of diseases, usually relapse adult diseases. They're not doing any clinical trials in children right now, although there's some move to partner with the COG in the future. They have opted for a strategy to combine their immunotherapy with other immunotherapies, mostly the antibody treatments that block PD-1 and CTLA-4. Indoximod is under development by New Link Genetics, and it's the second of the 2 drugs that are the furthest in development, and it's the oldest drug that was invented in the lab that I did my PhD in. And it's being used in a variety of adult cancers, entering phase 3 trials for adults, and it's in phase 1 for children. And it's the only drug on this whole list that's being developed currently for children. So that opens the question, how do you cross this bridge of developing a new technology in kids where the economics argue that there's not a good business reason to take the risks? Well, the adults, like I said, are probably 5 to 10 years ahead of us in this development, and the paradigm in pediatric drug development has long been that the pediatricians have to wait for a drug to be approved by the FDA for some adult indication, and then we use it in off-label fashion in our clinical trials. So now you can write a prescription, go to the pharmacy, and get it. You don't have to ask for any permission. The drug company doesn't have to provide you the drug because it's commercially available. This is a drug and really a whole class of drugs in large part that isn't at all available in any one of those avenues. So really the drug company has to agree to provide it. We have to write contracts for that to happen. We have to negotiate with the FDA about how we're going to run our trials safely and not hurt children that otherwise would not experience certain toxicities. And so it's a really long process. And just to point out, when we started, well, I wrote the trials, so I can speak to this in really granular terms. When we started writing the clinical trial, not only was there no preclinical data from the lab, but the IDO-inhibitor drugs as a whole class had never been used to treat any single child. It had never been used to treat anybody with any kind of brain tumor. It had never been used in combination with any radiation therapy, and never been used with some common chemotherapy drugs that we use for brain tumors like temozolomide. So we had a lot of work to do, and a lot of this foundational work we had to do in the lab as preclinical data in models of brain cancer, so that we could get the FDA and the drug company to really take us seriously. So this is just sorry, the title's cut off. This is just a snippet of the preclinical data, but to show that this is an actual glioblastoma sample from a pediatric patient at initial diagnosis, and the red staining is all IDO, and we've done that in a lot of archival samples for a lot of different pediatric brain tumors and found a high percentage of these tumors do have IDO staining in them. Even if they didn't, we would have done the clinical trial because the target IDO is expressed by the patient's immune system and not the relevant site of expression is the immune system and not really the tumor itself, but that was helpful data. And then this is an animal model where we implanted brain tumors and then treated with a combination of temozolomide and radiation. And if you get no treatment at all, the animals succumb to their disease in about 3 weeks. If you treat with chemoradiation, you get about a 2-week survival advantage. And if you add indoximod to that, we were able to actually show that you get a reasonable increase in survival advantage. It's about a 50% increase relative to not having indoximod. And so that, and then we were able to show a lot of innate inflammatory markers were coming up after the treatment, but only when you blocked IDO. And if you didn't block IDO, you didn't get all of that innate inflammation in the tumor. So that was part of the data that we took to the drug company and the FDA in order to start working on this early phases of the clinical trial. And so just a rundown for educational purposes of the stages of drug development. We're at phase 1, about to enter phase 2 in some cases. But the phase 1 investigation will be ongoing for some time still. Phase 0 studies are really pilot studies looking for proof of concept, very low numbers. You're basically looking to see if something is feasible to do at all. Can you deliver the therapy in the clinical setting in a way that, that you can do it reproducibly and safely? Phase 1 is you're really looking for the best safe dose to do the next clinical trial in. You're cataloging toxic side effects. There are usually not enough patients in a phase 1 study to see a treatment effect. An impact on outcome is usually, we include those in our objectives on the off chance that we actually see one. But it's usually the phase 2 where you're looking for preliminary evidence of effectiveness or efficacy. And that's where you're confining, different from a phase 1 where you may take all types of cancer, all patients who have relapsed brain cancer. It's really a mixed population of different types of cancer in phase 1. In phase 2, you're looking for preliminary evidence of efficacy. For statistical reasons, the patients have to be much more similar. And so you enroll patients with a very similar tumor type. Historically, it might be a ependymoma, or it might be relapsed medulloblastoma. But these days, we have genetically based categories that subdivide each of these major tumor types into several. I was recently at a conference where they suggested that medulloblastoma actually should be divided into 9 groups instead of 4. So it's and in pediatrics we suffer from a problem of being able to fill these clinical trials because we're trying to take a sliver of the total number of patients with cancer, and every time we create a new sliver, we're pushing a lot of patients out of the trial. We're saying that, you know, this huge group of patients won't be, we're going to take this 0.1% of all cancer in kids and try to fill a clinical trial with it, so it becomes hard. A lot more patients enroll in the phase 2 in order to get a statistically significant sample. It's powered to just barely show a difference, okay? So the question is, are we going to go to the expense, trouble, and potentially put patients at risk to do a huge phase 3 trial, which would be a population-based, statistically relevant sample. And so you're trying to answer that question in phase 2. Usually there's a control group. It can be historical data that is relevant to the patient population, or it could be a separate arm that gets either placebo or alternate therapy. Sometimes those are randomized, sometimes they're assigned. The phase 3, these are very large multi-site trials. You're trying to capture the idea that the therapy can be delivered at any site that takes care of this level of patient disease, and that you have a statistically relevant improvement in outcome with low enough toxicity that it's worth trying to get the drug approved so that it can be sold in the pharmacy. And then phase 4, these days there are a number of ways that you can accelerate this process so that drug testing before it's approved. In some cases, it's less than it was in the past, and the phase 4 post-marketing studies have become more important in those cases. But they've always been around, where the drug companies would have to continue doing studies to see if there are certain types of drug interactions, or if there are late effects that you wouldn't have captured in your short-term phase 1, 2, or 3 studies. So the overall hypothesis for our phase 1 protocol is combining immunotherapy with aggressive reirradiation using IDO blockade can act as an endogenous vaccine to activate native immunity. I call this native immunity because what you're doing with the radiation is creating a synchronous wave of cell death, and in a highly inflammatory environment in the tumor. Radiation causes a huge amount of inflammation that can act as an adjuvant in analogy to vaccine. So you're creating a huge amount of cell death where you have altered protein antigens from the tumor by virtue of their multiple mutations, and high inflammatory baseline, which we hope will drive robust immune responses as if it were an endogenous vaccine. This is different from a vaccine that's engineered in the lab, because you have to decide what altered protein or which protein, maybe it's a selection of proteins, but there's a limit to how many components of the immune system are going to become activated. Only what you put in the test tube will be driving responses. Here, it's everything in the tumor that could possibly drive an immune or inflammatory response will be involved in that endogenous vaccine. But we think it's important to follow that with cycles of re-stimulation. So these are like booster shots for the endogenous vaccine. And that's where we think that cycles of chemoimmunotherapy come into play. And so when we do the radiation indoximod, we always follow it with multiple cycles of chemotherapy indoximod in order to boost those responses. In immunotherapy trials in adults, it has not been a trivial finding that a lot of those patients get late responses. If they sometimes have stable disease or better for long periods of time before they have a dramatic decrease in tumor load. And so if you took those patients off early out of frustration, you would not have gotten to the point where you had potentially a significant response. So if all of that works, we think the resulting anti-tumor immunity might allow what I talked about before, which is for us to dial back the intensity of the chemotherapy and radiation therapy backbone regimens and still maintain effectiveness. That's a huge issue, because if you can do that, you decrease toxicity dramatically. Most of the toxicity of chemotherapy is driven by the last dose step from its clinical trial, which would be the last 20 to 25% increase to the current dose. So if you can back down on the dose by 25%, maintaining efficacy, your toxicity is going to go down dramatically. So this is the schema of the clinical trial. It's actually a very complicated clinical trial, but it's grown over the last 3 years to accommodate certain issues that we discovered while treating patients, and to include more patients. We started with 2 dose escalations that were dedicated to find out the right dose of indoximod to use in combination with chemotherapy and the right dose to use in combination with radiation therapy. So group 1 is called the core regimen, and it is trying to find the right dose of indoximod to use in combination with temozolomide. The temozolomide is given in a standard dose and 28-day cycles. The indoximod, the way we do dose escalations is we enroll a few patients at a low dose. We see if that's a safe dose to give. If there's not a whole lot of toxic side effects, then the next few patients we enroll at a higher dose and we go up. So we've actually completed this, and we found that there was no limiting toxicity, and we've chosen the highest dose that we tested as the dose that we'll go forward into phase 2 with. Group 3 was using upfront radiation with indoximod to see if the drug is a radiation sensitizer. Does it magnify radiation-related side effects in any way that's meaningful? or dangerous. And again, we found that it really didn't contribute to radiation toxicity, and we're going to use the highest dose level that we tested, which is thankfully going to be the same dose level for both groups. So those two are complete. And a quirk of this trial, and I touched on this a minute ago, is that for patients who might end up with a late response from the immunotherapy, we didn't want to make them have to come off the treatment early for an isolated progression, a single MRI that looks like a progressing tumor. If you have an active immune response in a growing tumor, often, and the adult studies actually bear this out, often the next MRI can show a swollen tumor. It can have more contrast deposition inside of it. Those can be features of an inflammatory response, just like they can be features of a growing tumor. So one MRI sometimes doesn't tell you a whole lot. There's not a lot of margin for error. If you have a growing tumor that's big enough in the brain, it usually causes significant symptoms. So the other thing that we take into account is the evolution of symptoms. If we have an asymptomatic or a patient with no change in baseline symptoms who might have a larger tumor on the first MRI or it has a brighter contrast, we often continue treatment. And we might continue with temozolomide. If we get a sense later on that there's a pattern of progression, we've had cases where we had multiple metastatic lesions where all of them were responding initially, but after several months, one tumor or two tumors began to grow. Is that a situation where you give up on the treatment? The target of the immunotherapy, again, is the immune system and not the tumor. What that tells me is that something about a tumor has figured out how to be resistant to the cycles of chemotherapy that happen once a month to damage the tumor just enough to re-stimulate immune responses. And if that's not happening, then you can get escape lesions. So we built in strategies to reestablish local control in situations where we might have escape lesions. And that might include surgical resection, another round of targeted radiation in patients who could get that, or crossover to a different chemotherapy regimen while continuing the indoximod. And that speaks to a metric I'm going to show you on the Kaplan-Meier curves in a minute. We often talk about progression-free survival, but that presumes that you're going to come off the trial as soon as you have your first progression event. And like I just said, a lot of patients have their first progression event at the first MRI because the tumor looks bigger, it looks more inflamed because maybe the treatment's working. The next MRI, it maybe looks better. And so if we now used an immune-related response criteria that takes some of those early events into account. And so you can continue treatment, and if you get a response on the back end, you can still count that as a response and include those patients in the surviving portion on a PFS curve. But if you go on and do another surgery, another round of radiation, another type of chemotherapy, you've now departed what we typically consider progression-free survival in clinical trial design. So we need a way to capture what that brings to the table for these patients who are essentially in end-stage disease. They have a few, the average is, the median survival for this patient population with no intervention is around 4 months or so. And so, it's really end-stage disease. And if we're bringing another 6 or 10 months to the table with some of these additional modalities, that's really beyond what you would expect from end-stage disease. And so we use time to regimen failure to capture the whole of the treatment and PFS. So we look at both. Time to regimen failure is the time from the start of treatment until they come off of indoximod treatment, and it's for whatever reason they come off indoximod treatment. But that captures a change in chemotherapy, additional radiation, additional local control, like surgery.
How do you define
It can be, it literally is when the patient stops therapy. So when they stop indoximod, that sometimes is because the parents have decided not to continue. Sometimes the parents have decided not to do another surgery, not to do another round of radiation. Maybe we can't do those things for this particular patient. Maybe they have symptomatic progression with a rapid evolution of symptoms that would make us not want to not believe that we can get it back under control with this treatment and maybe any treatment. But it's for any reason. Yeah. And then there's two other arms, and these are both still open. The group 2 is a series of expansion cohorts that we can expand into phase 2 powered study if we increase the numbers. That'll be dependent on whether or not we see an outcome signal in those specific disease histologies. And we just added the DIPG patients. It's actually a pilot cohort of 6 patients in group 3, and then we'll move into an expansion cohort in group 2. And that group is allowed to do upfront radiation for patients who might benefit from that, combined with indoximod, followed by chemoimmunotherapy, or they can start with chemoimmunotherapy, and if they need radiation later, they can still get it. The exception of that is the newly diagnosed DIPG patients all start with radiation immunotherapy. And then group 4 is just the crossover arm to the alternate chemotherapy platform that we use, cyclophosphamide and etoposide. We've enrolled actually 42 patients now. I have interim data analysis on the first 29. And those are the patients that filled the dose escalations in group 1 and group 2. So we have an interim analysis with a data cutoff of September or October, so it's fairly recent. We now have enrolled 42, as I said, and that's in the first 40 were enrolled in less than 2 years at 2 sites, which for pediatrics is reasonably brisk enrollment. There's a male preponderance, but that's true of all relapsed brain cancer in general. And our median age is about 12 and a half. It had been about 11 for a long time, and I think it might be back to that in the most recent enrollments, but it's a reasonable median. We've been enrolled in this cohort of 29. We had 14 ependymoma, 9 malignant glioma, and 6 medulloblastoma relapse cases. This is a progression-free survival curve, and this is historical control data, so that you got some idea of what our clinical trial data means. The solid line is a recent study looking at lapatinib and bevacizumab for relapse ependymoma patients. And then the open markers are progression-free survival, and the closed markers are overall survival at 6 and 12 months, depending on the study. For medulloblastoma, where they were using temozolomide in relapse setting, high-grade glioma, where they were trying to add reirradiation to other standard chemotherapy platforms, and then all recurrent brain tumor studies in the Fangacero abstract, where they were looking at pomalidomide in mixed population. And so, by and large, the 12-month PFS is around 20% or lower in all of these studies in different histologies. So this is the trial data to date, and the blue line is the time to regimen failure that I told you captures all attempts at salvage after first progression. The green line is first progression after any early inflammatory related events. It's first progression that would have taken the same set of patients off the study. So that's a comparison of the two ways to analyze the data, showing the PFS and time to regimen failure are not greatly different in statistical terms. But importantly, for some patients, time to regimen failure is much longer. I have one patient who's entered the 3rd year of indoximod-based therapy, after 7 or 8 months on the parent therapy, he's the one who piloted the switch to oral cyclophosphatide with indoximod and stayed on that for 14 months. So he was on that twice as long as the parent treatment. And in a disease population where the median survival is around 4 to 6 months, that's significant for that patient. So I do think that that we have to do the analysis in both ways, show the field the PFS, but I think that the time to regimen failure might be the better analysis for combined regimens like this one. And then the 12-month PFS was 41% in this patient population, which is significantly, which is demonstrably better than the historical controls.
Sorry to interrupt.
Yeah.
Even if you don't go, because it is confusing, right, with the progression and time to regimen failure. But even compared to if you look at overall survival, it's so much better than overall survival. So even if you can't compare the PFS.
We look at time to regimen failure a little bit as a proxy for overall survival in some ways, because most kids who leave the trial don't survive very long after that. There are a few who've gone on to other treatments that temporize for a few months, but so in some ways the TTRF might just be a proxy for overall survival. So we knew when we wrote the clinical trial that the animal models were showing a dramatic effect of radiation therapy in combination with indoximod. So this is an analysis that breaks out the radiation patients, and because the bulk of these patients got radiation as a group 3 patient as upfront radiation combined with indoximod, but a selection, about four of the patients on the red line here got radiation later in their treatment as a group 1 patient. So what we did was we said anybody who ever got radiation while on indoximod is in the red line, and anybody who couldn't get radiation is in the blue line. And so there's 13 patients who couldn't get radiation, and there's a tail of effect. By and large, there's a steep drop-off, just like historical studies, but there's a tail of effect that's still about twice as good as the historical studies. So the chemo indoximod is bringing something to the table for a select subset of patients. We have no idea how to find out who they are right now. And they're all different, so it's really not clear how to tell who they are. But the radiation, adding radiation to the treatment had a significant effect on time to regimen failure for the 16 patients who could get radiation. So that's a p-value in a very low powered study. There are very few patients to compare, and so that's a fairly significant finding. And then I made a big deal at the very beginning about the idea that some patients, like the ependymoma patients in first relapse who can get full radiation to all sites of disease, they may do well, median survival up to 2 years or so. They may do well just by virtue of the fact that they got full dose radiation a second time. And so how do you tell if your radiation effect is just being contaminated by a lot of those patients who may have just got... it turns out that we actually have a lot of non-ependymoma patients. We have a lot of patients that we didn't irradiate all sites of disease. And we have a lot of patients who couldn't get full dose reirradiation. So of the 16 who could get full dose reirradiation at 50 gray or higher, there were 8 of them. And so these are those 8 compared to the same 13 that couldn't get radiation at all. So they are doing better, but the p-value is slightly below or above 0.05, so it's not a statistically, we've lost our statistical significance, but maybe that's because we dropped half of our subset. Very low numbers to compare here. Interestingly, I want to point out that 75% of these patients, 6 out of the 8, had gotten radiation to all sites of disease that we could see on the MRI. So we radiated everything in those patients that looked like it was tumor. And so maybe that's why they're doing better. Why am I making a big deal about this? Because our main hypothesis was that if what we're doing works and the radio-immunotherapy followed by cycles of chemoimmunotherapy actually acts as an endogenous vaccine with booster shots, then scientifically it's not a long leap to say that you ought to be able to dial back the intensity of the toxic chemotherapy and radiation therapy modalities and maintain your effectiveness. And so when we looked at the 8 patients who could not get full dose reirradiation, it turned out that all 8 of them got 30 gray or less, so almost half or less of what the patients on the left got. But they actually were doing at least as well as the patients that got full dose radiation. Not only that, but the target volume was only 2/3 of the target volume in the patients that got full irradiation. So we pulled the fields in. These are patients that were very complicated. They had prior radiation. We had to avoid those radiation overlaps. In some cases, we couldn't and didn't want to get wide margins. And maybe that's a good thing, because all of your radiation toxicity comes from that rim of normal brain tissue that you have to radiate and get a margin on in order to get a cure. If you're using radiation to brutally eradicate every tumor cell, you have to do margins on the edges. But if you're using it to stimulate an immune response, we felt like you could draw in those fields and do the radiation safer. We didn't shy away from doing lower doses of radiation where it made sense for the patient. And interestingly, only a quarter of these patients could get all of their disease radiated. We intentionally left unirradiated disease in 75% of these patients, and they're still doing at least as well with a p-value of 0.03 as the patients who got full dose radiation. So as far as I know, that's the first empiric evidence in the clinical trial setting that you can actually dial back the intensity of cytotoxic therapies when you combine them with immunotherapy. So that's a very significant finding. And then I just want to finish in the last 10 minutes or so with some visual examples of kids who have been on the trial and how they've done. Jed Wolchuk is pioneering the field of T-cell checkpoint blockade, and he's probably treated more patients than any one person and up in New York, and he has described in the literature 4 responses to immunotherapy, 4 patterns of response. One is that you immediately respond like you would want to, and the disease goes away and you stay cured or minimal disease. A second pattern of response is long-term stable disease that doesn't qualify for a partial response on numerical grounds, but is still controlling the disease and its symptoms in a way that's acceptable. Another, I've talked about this a minute ago, is that sometimes you get an increase in volume or other characteristics on the MRI that may be highly worrisome for progression, but then later the tumor may respond. And then a fourth, and these last 2 are very characteristic, I would say, of immunotherapy. You sometimes see this in radiation therapy, but you don't really see this last one. This one is, this top line is the sum of the 2 lower lines. This dotted line is a second tumor that showed up while this patient was being treated. And that's a progression, and no matter how you write the books, that's a progression. When you have a new tumor while you're on a treatment, we usually stop treatment and think about something else to do. But sometimes these patients actually have that new tumor respond to treatment if you continue it. So I favor those, especially when they happen within the first few months of treatment, as existing disease that was actually present when you started treatment, but is now visible on MRI because it's inflamed. And so that we have not shied away from continuing therapy in those situations in the kids either. So standard pattern of response, this is an 11-year-old with metastatic medulloblastoma who started with radiation indoximod. This patient had 15 to 17 tumors. The leptomeningeal deposits were hard to enumerate, and But at the start of treatment, at least 15 tumors that number decreased to 4 to 5 areas of identifiable disease before he began to progress after about 10 months of therapy. But he had a dramatic response of about 95% of his disease over time. And so you can see, as you follow across cycles of therapy, that these various tumors are actually responding. And here are different cuts in his brain where you can follow. There's a tumor there too that I didn't put an arrow on. There's 2 here in the posterior fossa that responded over time. Sustained stabilization of what was growing disease. So you have to have relapse or progressive disease when you start the treatment. So by definition, you have growing disease when you start. So here's a 19-year-old with metastatic ependymoma who didn't get radiation up front, just cycles of chemo immunotherapy, and he had residual tumor in his primary tumor bed in the posterior fossa that was essentially stable over a long period of time, and he had 2 lateral ventricular tumors that also remain stable over time. He's now just started his 17th cycle of therapy, and these tumors remain stable to this day. So what happens when you stop treatment? When do you stop treatment? I don't know. I honestly don't know for patients like this. At some point, if they declare an aggressive progression event, and you're still on treatment, you just do something else. But if they never do that, when do you stop? There's case reports of patients being treated up to 3 years on temozolomide-based regimens, so I'm not in any big rush with him. So what about these 2 that I said were very characteristic of effective immunotherapy? So an initial enlargement followed by improvement. So this is a patient, 12-year-old, who had Li-Fraumeni, initially had a medulloblastoma in the posterior fossa, treated with resection, full-dose radiation, multiple tandem transplants, and St. Jude protocol. And then they found out he had Li-Fraumeni syndrome. And so several years later, not that many, maybe 3 or 4 years later, he developed a glioblastoma in the same tumor bed. And he was resected by 2 separate surgeons, full resections. Within 4 weeks, the tumor grew back to the exact same size. He had an experimental laser ablation technique attempted that also failed. And then he met us and we enrolled him. And the day we met him, he was symptomatic, and we sent him to our neurosurgeon for surgical debulking so that we could at least have a time window to get started. He then had so this pre-treatment MRI is actually a post-surgical MRI after that debulking. And then after radiation, the tumor swelled a bit and lit up with contrast. And that continued for a few months until it began to actually shrink and respond. This is a kid who was highly debilitated in a wheelchair, couldn't walk because of balance issues and severe diplopia. And during his radiation developed multiple additional bulbar symptoms. But for palliative reasons and really just no other options, we continued his therapy. And in the second half of his radiation, he began to get better. And that began a steady march to him recapturing function over the next 3 months or so. He eventually was back in high school or middle school, walking to his own classes, carrying his own books, and his teachers took him out of regular classes and put him in honors classes. Ultimately, he did progress and succumb to his disease, but that's the quality of life that we were able to give him in his end-stage time. And then this pattern is very important. So what happens when a new tumor shows up and you're on treatment? This is a patient, a 14-year-old, who had isolated CSF relapse of medulloblastoma, so didn't have an anatomic lesion, but had cytologically positive cerebral spinal fluid, and no open clinical trials would enroll a patient, and they asked me to enroll, and I said, let me read the trial. I wrote it, but I really don't know. So I read it, and there was really no prohibition. We just didn't think of it. So we didn't make we were just silent on that. So we decided to enroll her. She's had 5 sequential CSF negative samples at 2-month intervals since we enrolled her, starting at the second, after 2 months of therapy, all the way up till now. She's now maybe starting cycle 9 or 10, and it must be 10. She's had 5 negative CSF samples, but after the first 2 cycles of therapy, this thecal mass highlighted by the red arrow showed up. And we had to make a decision about whether, that represented a progression that we should stop this treatment and look for something else, or whether we should continue. Intellectually, I made the argument that this disease might have always been there. It might have been the source of her CSF positivity. It might now just be inflamed and able to be seen on MRI. So the family, and she was completely asymptomatic. She's on a volleyball squad and is a team captain, and so she's a very active girl. And so she wanted to continue, her family wanted to continue, and so we did that, and that remained stable for some period of time, and then began to regress on the back end. So that type of case, and we have 4 or 5 of these now, where we've seen new tumors crop up that then stabilized or began to get better later. That is why I point out time to regimen failure as a metric that we really need to include with immunotherapy trials. And I think if we stick to standard PFS, we're really losing what might be a larger magnitude of full effect in these clinical trials. And then as far as the trial's been very safe, there have been, in the radiation arms, there have been about 15% of the patients had delay in starting their maintenance chemotherapy regimens, and about 11% of cycles have been delayed, of chemotherapy indoximod cycles have been delayed, mostly for marrow suppression. And that's out of 158 total temozolomide indoximod cycles as of a few months ago, when we had 13 fewer patients. And about 40% of patients eventually get a dose reduction in temozolomide to 75%. But for a large part, this treatment is very well tolerated. The severe adverse events are things that put you in the hospital for any reason. They've been self-limited and manageable for most part, mostly revolving around infection or immune activation type events, or tumor progression, and very relatively low attribution to the study drug. So remember, the overall goal was to use immunotherapy in combination with standard therapies to re-engage, to reintroduce the idea of aggressive therapy in a patient population where you're really dealing with end-stage patients, and often is viewed as a futile treatment. But this is an example of why we do it. The quality of life issues, and we've watched several of these kids literally regain function before our eyes. This is another patient who was literally in a wagon when I met him because of a spinal tumor, and he couldn't walk because of the pain. 6 months into therapy, he's climbing rock walls and running the bases at our local minor league baseball field. And so, and he is the patient who's just started his 3rd year on a third chemotherapy platform. Recently had progression. We did another surgery, another round of radiation, regained some local control, and we're actually treating him with indoximod combined with gemcitabine, Abraxane, and Herceptin. So I can talk to you about that. It's an interesting regimen. So first empiric evidence that immunotherapy combinations with standard therapy can allow you to reduce the intensity of the cytolytic therapies, but also indoximod is very well tolerated at all dose levels studied, and doesn't really compromise the ability to deliver the backbone chemo and radiation. And I can stop here. We have, interestingly, just opened the trial up to newly diagnosed DIPG patients and enrolled the first 3 patients. And this is our first patient in Augusta who had a really huge pontine tumor. I don't think I have to point to it. And he has just finished his radiation indoximod block, and the post-radiation MRI is very encouraging, which is why we're probably going to expand that arm a bit. The phase 2 trial is in formal development, and we'll use it to formally test the hypothesis that low-dose radiation can be as effective as the high-dose radiation. And with that, I'll take any questions. I know we're running a little bit late, but I apologize for that. Thank you.
When you have resected the lesions that are progressing, are you analyzing those to see if they look predominantly like inflammation versus tumor?
Yes, so we're getting those. The surgeries happen all over the country, but the surgeons have been remarkably helpful in getting us tissue. We have spent the last year and a half working out techniques to analyze those. We have limited number of slides that get sent to us, so we've been working on a multi-parameter immunohistochemical platform using a Vectra machine that we've just about got it worked out so that we can start running through those. We've sort of archived them as we got them. But one thing that we have heard the surgeons say multiple times, and they're not in the same surgical group, they're all over the place, is that the tumor doesn't look like it should. The tumor looks less vital than they expected. The most recent, the patient that's starting the third year of treatment, Rick Boops, his surgeon up in Memphis, and that's what he told the family. And we hear that both directly from the surgeons and from the families very frequently. So I don't know, maybe the escape lesions just have to be different in order to be growing, but they definitely look different to the surgeons.
It would be great to have a standardized way of
Yeah.
those posts. And also,
Yeah.
have you done any like rapid post-mortems?
Well, so we haven't, but one thing about getting the escape lesions is that those are cases where the treatment's failing. So they're not going to tell us about what markers we should be looking for in a responding tumor. And we don't know which ones are supposed to be there in order to know to look for what's missing in the escape lesion as far as inflammatory cues and which immune cell cohorts are supposed to be there. So one of the things that we built into this trial was an upfront in the group 2 patients, we can approach the families, anybody who would qualify for surgical debulking, we can approach them to do a shortened neoadjuvant cycle where they get exposed to temozolomide and indoximod for 5 to 7 days before their surgery. And because in the animal models, the inflammatory events happen very early. So we thought that was a good way to try to begin to get biomarker information so we would know what to do with these escape lesions. So you need to know what is there in a responding lesion to know what is missing in an escape lesion. We are also working on developing some dynamic real-time testing from blood, looking for T-cell cohorts and actually myeloid cell cohorts. It turns out that we think you can get a circulating myeloid population that is a stimulated phenotype, in addition to what might be happening in the tumor in these patients when they're having active therapy. So we're beginning to get flow data on patient samples in real time. That's just over the last 6 months or so we've been developing that. Then the third thing we're doing is doing genetic analyses of the T-cell locus for outgrowth of clonal evolution of T-cell clones in blood samples, but then we're going back and looking at the diagnostic tissue that we may have to see if those were there all along and maybe have been amplified after treatment started. So those are the kind of things we're looking for. Thank you.